All right, welcome, folks who are joining. The room is open, so we're going to give it just a few minutes to let people join in. Hope everyone is doing great. We were all just talking while we were waiting about the storm coming through, so we're hoping that folks are in the path of the snowstorm are able to load up on your meds, make sure you've got everything you need. It's always kind of fun when we all come together and do this, but it's also a little unnerving, especially thinking about patients and meds and things like that. So we're going to give it just one more second. We'll start once we see the room slowing down in numbers. We have a little over 100, 125, 150 people registered for tonight, so that's great. We know January is an incredibly crazy time of people getting back in the swing of things. So, okay, it looks like our room has slowed down, people joining in. So, I want to welcome everyone. I'm Carrie Howell, the CEO of American Migraine Foundation, and it's such an honor to be here with this esteemed group of ladies talking about children and teens with migraine. And I am just always so honored to kick these off and welcome you all here. I want to welcome the participants here. We don't take it lightly that you give us your time and that you let us be part of your journey. And so, with American Migraine Foundation, if you haven't joined some things we've done before, we do monthly webinars. Our website is chock full of just amazing resources. One of the things that really sets us apart is that everything we write, everything we share on social is verified by our clinicians. And so we take that very serious. And we actually just spent some time on that today about there's so much good content that we want to send to you. And what we really try to prioritize it and make sure we're putting what's relevant to you out as well. So I did want to share a couple of things that came up. We did not have our webinar in December because of the holidays, but you all probably saw that we have a new AMF store. And I wanted to just share that really our reasoning in that is there's a small piece of fundraising in it. It's very, very small. The bigger picture for us is to make sure we are bringing awareness to migraine. And so we'd love for people to go on and have stuff in their shirts and water bottles. I actually have one of those here. Oh, I don't know if you can see it because of the background. This one's super cute. Um, but we also have something really neat right now. If you haven't seen our I Am Visible migraine pens, one of the things we really want to do with this is say that not only do we know migraine is a debilitating brain disease, but it's so real that we wanted to depict it in an image for a PET scan. We've kind of envisioned that physicians wearing this or patients wearing this or caregivers and saying, "Hey, this is a depiction of what migraine looks like." And so we really have put a labor. There's been a labor of love with this, but this image is also on things that are in our store, and so we'll add it in the chat, which it looks like they just put it in. The NeuroBloom pens are sold on a different website, but there are items in the store with this depiction. So I just want to welcome you all. Thank you to the panel tonight. Looking forward to hearing the discussion, and welcome to AMF if this is new for people. So I'm going to jump off, and Dr. Sando, I'm going to turn over the reins to you.
Scary and
Thank
good
you.
evening to everybody. Thank you so much for taking your time to join us. I'm Dr. Claire Sando. I am co-chair of the AMF editorial board. I'm a headache neurologist in Toronto, in Canada. I'm really looking forward to talking with some of the really great experts that you see here on our panel tonight about migraine in children and teens. And we're going to spend just about 45 minutes talking, and then we'll have time for question and answer at the end. Please do put all of your questions in the Q&A as we go. We'll do our absolute best to get to as many of those as we can. And in case anybody is interested, we're going to be recording this webinar and it should be available on our website after the event as well. If there's something that you really want to rewatch, or if you want to share this with any of your friends, you'll be able to do so afterwards. So I'm just going to briefly introduce my esteemed colleagues and then we'll hear from them a bit. And so in no particular order, Dr. Rashmi Rao, who is an associate professor of neurology at Louisiana State University Health Sciences Center, and she is a specialist in pediatric headache. She has great headache credentials like all of the people here, and I'm actually going to shorten their bios if that's okay for the sake of time, since we have so many good experts with us tonight. But she does, in addition to her clinical work, some research on pediatric headache disparities and expanding access to child neurology care. So thanks for being with us, Dr. Rao. Dr. Serena Orr is a pediatric neurologist subspecializing in headache medicine from the Alberta Children's Hospital in Calgary, Alberta, Canada. So she's a fellow Canadian to me. And she is a clinician scientist, in fact. And so, in addition to her clinical work, she also has a big interest in clinical research, in particular, acute treatment of migraine, technology based treatment, and understanding psychosocial factors impacting migraine in kids and teens. And then Dr. Samantha Irwin, who is a board certified associate professor of pediatric neurology and headache specialist at the University of Texas at Austin Dell Medical School, where she directs the headache medicine fellowship. And she too does both clinical work and research. She's participating in some clinical trials about treatments for pediatric and adolescent migraine, some of which we'll probably hear about tonight. And then last but not least, Dr. Caitlin Green, who's a pediatric neurologist specializing in caring for children and adolescents with headache. She directs the child and adolescent headache program at the Dornbucker Children's Hospital at Oregon Health and Science University in Portland, Oregon, where she's an associate professor in the Department of Pediatrics. And again, she also has some clinical and research interests that I'm hoping we'll hear about tonight. And she is also on the editorial board of AMF. So thank you, everybody, for being here. I'm looking forward to hearing your insights. I think we'll just maybe start by talking about what migraine might look like in kids and teens. And so, Dr. Rao, I'm going to ask you if that's okay to kick us off by telling us a bit about how you tell whether something is migraine versus some other type of headache in a child.
Yeah, I think that's such an important question because it so commonly comes up. But I always kind of start with the fact that 1 in 11 children and adolescents have migraine, right? So that's such a huge number. And if you think about all of us that are on today, most of us in pretty much all of our practice are doing headache medicine. And I think that's huge. When you differentiate different types of headaches, it really comes down to what are the characteristics and what other associated symptoms might be with them. So, for instance, a lot of families come in with concerns of, is it the glasses? Is it allergies? Are these causing my child's headaches? And so if you think about like an allergy associated headache, they may be associated with that runny nose and things like that. Or if you think about like a glasses, it might happen after we've been looking at a board for a long day and the child says, hey, I can't see quite properly, like I strain. But when you think about a migraine attack and that migraine headache, that's very different. So there are strict criteria that we think about. They can last anywhere from 2 hours to 72 hours without any treatment. They're really moderate to severe in pain, worse with routine physical activity. They can be located on both sides of the heads in kids. And then they also can be throbbing in quality. They also may have like stomach ache or nausea or feel that feeling of throwing up, even decreased appetite, or they might vomit. But they also may have light and sound sensitivity. And so those are kind of the things that we think about when we're seeing them. But also as a parent might be something that you think about and say, oh, well, that's a little different if my child is saying their stomach hurts or they can't eat or even they can't function. And so that criteria really helps us make that diagnosis, but also kind of tunes in for a parent that maybe this just isn't the type of headache they were thinking about.
Thank you for setting that stage. And maybe I imagine that some of our listeners tonight are parents or people who live with migraine themselves. Can you tell us a little bit about how it might look different in an adult than in a child?
Absolutely. So the time frame of a migraine attack in children and adolescents can be much less, right? In adults, we say it's kind of like from 4 to 72 hours without treatment, but we said it's all the way from 2 hours or maybe even less for children. We also know that we can infer from their behavior if they're laying down, going to sleep, non-functional. We can take that into account. And with adults, we usually see it on one side of their head, but like I said, for kids, it can be anywhere. So that's some differences in the criteria that can help us identify that migraine attack.
And some of these things sound pretty scary for parents to see. Dr. Irwin, can you tell us when we might know that more tests would be needed?
Yes, just finding the mute button. Hi, everybody. This is a question that comes up very frequently. And I think, every family's worried when they come to the visit that this is not migraine and it's something else. And how can we be so sure? So really everything comes down to the history. And that's why when you come to see a headache specialist, we usually take about an hour unpacking every single detail you've ever, wanted to share or thought of sharing about your headaches, from how they started and how they've evolved over time and the symptoms that are associated. For us, when we hear a story of someone who's having, intermittent headache or what we call episodic, that has been there for some time, maybe had changes with changes in menses or menarche or estrogen changes, might have a family history of migraine as well, with no what we call worrisome features. That's a type of headache that doesn't usually need any further workup, and is not a concerning headache to us. When we take that really careful history, we'll be looking for, certain abnormalities that might trigger us to think that the headache requires further workup. We can see those certain features on exam. There'll be certain red flag things that we're looking for on the neurologic exam that might alert us to a different type of headache. If the headache's, really abrupt in onset, really severe, continuous, if the patient might be really young, if vomiting is present and the vomiting's not just once in a while, but it's all the time and it never goes away, if the headache might be waking, the child up from sleep consistently, if there's, certain visual changes that are concerning, we'd want to know about that. Or if there's any other kind of neurologic signs or symptoms, that would prompt us to think about further workup that might include imaging.
It sounds like most kids will not end up needing imaging for their headaches.
Yes, most kids will not end up needing imaging. And, even when we do image, because we might be worried about a few things, most images come back normal.
Which is great for kids and families. And maybe just to sort of take us to the next part of our talk, Dr. Irwin, we're going to stay with you a little bit. Can you tell us just some thoughts about how you overall approach treating migraine in children?
Yeah, so I think when we think about an overall approach to treatment, I think it's really important to highlight that migraine is a spectrum. So many on the call today will have a different, a different, not severity is the right word, but a kind of a different impact of their illness on their day to day. So some people might have attacks that are quarterly, some might have monthly, some might be weekly, and there's an unfortunate subset that might be dealing with daily or continuous migraine. So the treatment strategies really vary based on kind of that spectrum, which is why a close relationship with your headache provider is so important for treatment. The goals of treatment also vary widely, and may impact kind of the strategy. Some might be seeking to have less frequent headaches. Some might be looking really only to shorten the duration of individual attacks. Others might really just be working on improving functioning, or some combination thereof. So I think it's important to have realistic kind of expectations about what's possible at treatments and also what your goals are. To take a step back, Dr. Rao was discussing initially that migraine is what we call a complex genetic neurologic disorder of the brain. So there is a number of changes that happen in the brain from a chemical level that lead to a migraine attack. And those genetics can't be changed, at least currently. So we think about treatment improving kind of the impact of the disease, knowing that it is a complex genetic disorder of the brain. The treatment strategies, we think about them in three main categories. So we have lifestyle treatments that really anyone with the genetics for migraine will likely benefit from. And we'll hear more about that. We have acute treatment strategies that are used during attacks, and what we call preventive treatment strategies that are often taken daily or some frequency between attacks. When thinking about acute treatments, the goal for us is either pain freedom or pain improvement, at least by around the 2-hour mark. And we know from clinical trials that is achieved in about 1/3 of patients for freedom and up to 2/3 of patients for pain improvement. And when we think about preventive treatments, the ones that are taken between attacks, we're really thinking about improving one's buffer around having an attack or building kind of resilience to have fewer attacks overall. The other way to think about it is like raising your threshold, even though you have the genetics for migraine. And with our preventive interventions, our goal is to, ideally make about a 50% improvement when we're consistent with treatment use for about 8 to 12 weeks. Sometimes we can do better. But rarely are preventives 100% effective, and usually the improvement is not immediate. It takes time. So I just wanted to set that stage as we move to the following sections. I think it's important to just remember these overall kind of expectations with treatments and caveats, so that everyone on the call as patients and as parents can have an informed conversation with their provider.
Thank you. And I think some of the things you said are really important. Migraine is, as you said, it's a lifelong disorder that can have more or less impact at different times. And so recognizing that and trying to collaborate with your headache specialist early on, right out the gate, is hopefully going to make a good impact for anybody living with migraine. So maybe we'll talk through those categories a bit. Dr. Orr, can you talk to us a little bit about some of the lifestyle changes that might benefit kids living with migraine?
Yeah, for sure. So the way I like to explain this to families is just starting actually with the brain. The first area of the brain that lights up even before the pain of a migraine attack is called the hypothalamus. And that's like our deep control center. We use the word homeostasis in medicine, but that means that part of the brain controls all the things we need to survive, like sleep, hunger, thirst. It kind of is the basic control center. And knowing that it's the first part of the brain to light up, even before the pain starts, we think that having a combination, any combination of enough internal or external stress, whether that's physical events like, having a fever or skipping a meal or going to bed late, or psychological stress, might perturb that part of the brain enough to set off an attack. And so we used to say, actually, even when I was early in residency, we'd give lists out to people of triggers to avoid. And now we know with more research where people fill out daily diaries, specific triggers are actually rare where like one particular thing is always the cause of an attack. But the idea of just trying to keep regular schedules with sleep and eating and adequate protein intake and learning kind of stress and pain management coping techniques can be really helpful from a lifestyle perspective. There's less research on the lifestyle factors than what you would think, but the ones that have the most evidence among those are the piece around sleep. So maintaining the regular schedule, trying to keep your bed and wake up time within a couple of hours of each other, getting enough sleep. There's some data on that, and a couple of studies in kids with migraine that show that sleep interventions can help. There's also quite a bit of research on exercise and getting adequate amounts of exercise, especially on the adult side, but a little bit on the pediatric side. So the recommendations for youth is, 60 minutes of moderate to intense physical activity per day. That's across all children, not specific to migraine. And that can be very difficult with migraine, but just trying to get enough exercise that the child can tolerate, we think can improve outcomes over time. There's less research on diet, but we think that regular protein intake so that blood sugar isn't going up and down a lot can be helpful. And then there's data to suggest really that substance use, regardless of what that is, whether that's vaping, smoking cigarettes, drinking alcohol, cannabis, or any types of drugs of abuse, are associated with higher headache frequency in youth. And so counseling around kind of substances is important and challenging. So yeah, that's what I would say is overall trying to maintain healthy routines while understanding that migraine is a neurological disease that's highly heritable, and it's not that we ever cause the disease, but just trying to maintain regular healthy habits is really helpful, with exercise, sleep, substances, and kind of regular food and water intake being probably the most helpful pieces of the day-to-day.
Thank you. I like how this sort of both, I mean, a couple of people have so far highlighted this. It's genetic. It's something that your brain is put together knowing how to do, and it's not necessarily your fault on a given day if it tips over into a migraine attack. I think that's really important for also my adult patients, but for anybody who lives with migraine to know. So thank you for that. So maybe we will go to the next sort of category of things that we do for migraine, and we'll talk a bit about acute treatments. Dr. Green, can you tell us a little bit about your approach to acute treatments?
Yes. So this is an area of migraine treatment that I think really anyone living with migraine can benefit from, having an effective and well-tolerated acute treatment. As Dr. Irwin talked about a little bit earlier, the goal of acute treatment, or what's also sometimes called as needed treatment or rescue treatment, is to decrease the duration and severity of a migraine attack when it occurs. For many patients who have episodic or occasional migraine, that means stopping an attack completely in its track. But there can also be other goals for patients with more frequent headaches or even continuous headaches, like reducing the intensity of the level of the attack back down to a more tolerable level. Other goals we sometimes think about are reducing other migraine associated symptoms like nausea or helping kids get back to school or activities more quickly. And just like with all migraine treatment, as I think you'll hear as kind of a theme throughout this webinar, is that there are often different layers of treatment that we can think about to sort of help augment kids' response to treatment. So for acute treatment, it can include anything from behavioral strategies like resting in a quiet environment, using deep breathing strategies or techniques, general pain-directed medications like ibuprofen or acetaminophen or other things you might be able to get over the counter, and then more migraine-specific treatment, like the category of medications called triptans that we'll talk about in a little bit. And sometimes it's a combination of these things, and deciding how severe the attack is from the onset can help you to determine which choice of medication is best for that attack. As a general principle, we talk about the fact that treating a migraine attack earlier is often more effective. We use the metaphor sometimes of putting out a fire. It's easier to put out a small flame than to put down a whole house fire. But that doesn't mean that medications won't be helpful if you take them late. We just try to target treating early when the attack first starts. I think another thing that's really important to think about with as needed treatment is there's many different forms of medications you can take to treat a migraine attack when it occurs. There are some that you take by mouth. There are some that are available as nasal sprays or even injections. So for example, if your child tends to have vomiting during an attack, a medication that you take by mouth may not be as effective because it's not going to be absorbed as well. So having a nasal option might be better. Other things to consider in that situation might be something like neuromodulation, where you don't have to necessarily take a medication, but you can use something to modify the attack outside of medication. And then the last point that I really wanted to make is that there are so many options available. So if you are finding that your as needed medications aren't working well, or they're causing bothersome side effects, I would definitely encourage you to talk to your doctor, or even thinking about seeing a neurologist or headache specialist who may have a bigger range of options to talk to you about so that you can find something that works well.
Thank you. It sounds like our goals for acute treatment are actually pretty lofty. We want people to go back to doing well and not have to go to bed and lose the activity and lose the day. So maybe we'll talk about some of those. Sorry, go ahead.
Oh, I was just going to say, and sometimes that is a combination of the medication working well, but also the medication not causing side effects. We really don't want to have your as needed medication make you so sleepy then that you can't function. So that's another reason to talk about other choices.
Thank you. We'll go through, I think, a couple of those potential categories of some of our more migraine targeted options. Dr. Orr, can you tell us a little bit about triptans that Dr. Green mentioned, those migraine targeted options for kids and teens specifically?
Yeah, so triptans were the first category of migraine-specific medications to be developed, and we've had them now for decades. There are 7 different triptans, and they all have slightly different properties in terms of how quickly they peak and how long they last, and then what formulations are available. So, like Dr. Green said, some are swallowed, there are intranasal sprays. There's oral dissolving tablets with various flavors, and there's an injectable triptan. And so in the United States, there have been 4 that have been FDA approved for pediatric use, either at 6 or 12 and over. And generally, the selection of the triptan, my approach is to kind of look at both the features of the attack, like Dr. Green was saying. If there's a rapid peak and or vomiting within the first 20 to 30 minutes, you're really much less likely to be having consistent success with a swallowed pill. And so we often then will look at other modalities like oral dissolving tablet, nasal spray, or injectable. And then, the second part of the decision is what is the child willing to take, both in terms of taste and modality. And so often children, actually, if you ask them, will have really strong opinions about that. And we know that the more the child and family are implicated into the treatment choice, the more likely they are to actually use it and have success with it. There's definitely, outside of headache specialty practices, unfortunately, sometimes still some fear and hesitancy of using triptans in youth. But like I said, there are 4 out of the 7 that have, FDA on label for pediatric use. And in headache specialty practice, we use the full gamut of them on the pediatric side. They're generally very well tolerated in kids. Of course, there are some patients that may have reasons that triptans wouldn't be safe, like if they've had a history of stroke or heart attack, or major heart rhythm abnormalities, for example. These would be situations where we'd be avoiding them or very cautious. But for the most part, they're very well tolerated in youth and can be used in combination with over-the-counter or prescription-based anti-inflammatories with medications that are used to suppress vomiting. And, sometimes in a headache specialty practice layered in with new G-pants, but that's very new and off-label. I did see a question about that we can get back to whenever is appropriate. But yeah, they're a nice option, and they work through the serotonin system. So they act on a specific type of serotonin receptors and help facilitate serotonin transmission in the brain, which dampens down the migraine pain signals.
And so we will indeed talk about GPANTs briefly next. And just to highlight the questions, I see that we're having several coming through the Q&A, which is perfect. Please keep sending them there. We're going to take those at the end. We're going to dedicate the last quarter of our session to that. So Dr. Green, can you tell us a little bit about GPANTs and whether they're an option for pediatric patients?
Yes, this is a great question and one that I get asked about more and more. It's been a really exciting time in headache medicine because we've had a number of new medications come on the market in the past 5 or 10 years. So GPANTs refers to this relatively new class of medications that work by blocking signaling of a pain signaling molecule called CGRP, or calcitonin gene-related peptide, that we think is involved in driving migraine. There are 3 GPANTs that are FDA approved for migraine treatment in adults, and none right now are FDA labeled for use in the pediatric population. Like triptans, they're specifically developed for acute treatment of migraine, so they're really migraine-targeted therapies. And they have similar efficacy in stopping migraine attack in clinical trials with relatively few side effects. But there are not that many studies evaluating their use in the pediatric population, although clinical trials are underway. And just because they're relatively new and we're still working on gathering data in our patient population, they're generally not used as a first choice medication in our children and adolescent patients yet. But that being said, we do sometimes consider them, or headache specialists may sometimes consider them for teens who don't benefit from triptans or really have contraindications to triptans, like Dr. Orr mentioned, like history of cardiovascular disease or significant cerebrovascular disease, like history of stroke. So that would be something to discuss in detail with your doctor or headache specialist, but really attending to sort of like the risk benefit of using newer medications.
Well, it's an exciting sounding time then, and hopefully if we have this webinar again in a year or two, we'll have new info to share about that as well. And so
yes,
maybe
fingers
Dr.
crossed.
Green, maybe we'll stick with you as we actually shift towards prevention, our last sort of category of things to talk about. What's your approach to preventive treatment and whether you think that one of your pediatric patients needs it?
Yes, another good question. So in contrast to as needed or acute treatments, where the goal is to really treat an individual migraine attack, the goal of preventive treatment is to reduce the frequency of migraine attacks or headache spikes over time, and also to reduce their impact on kids' function, improve coping, reduce their reliance on those as needed treatments. As Dr. Irwin said, I think about kids with migraine as having a threshold where if they hit that threshold with a number of stacking up stressors, they're likely to have an attack. The goal of the acute treatment is to stop the attack once it already is over the threshold. The goal of preventive treatment, I think of as trying to raise the threshold where your body can tolerate doing more things without having a migraine come on. The other thing that we really think about with preventive medication is balancing, again, the risk and the likelihood that they're going to be effective with the possibility of side effects or risks of medications. There's no specific approach to headache prevention that's right for everyone. And sometimes it really is a matter of trial and error to find the combination of treatments that's best for you. And also to echo Dr. Irwin again, so these treatments often take time to work. So especially with oral preventive treatments or pill-based treatments, we often say at least 2 or sometimes even 3 months of consistent use to really see benefit. So it does take some time and patience. As I mentioned with the as needed treatment, in many cases, this is often a layered approach or a multidisciplinary approach that incorporates the lifestyle measures that Dr. Orr talked about, sometimes medication, which can be prescription medication or supplements, and then psychology or behavioral based treatments, which I think we'll touch on in a bit as well. I really think about escalating preventive treatment in my patients, whether that means starting a supplement or a prescription medication or optimizing behavioral treatment. When a child or teen is having a headache more than once a week, especially if it's interfering with their ability to attend school or participate in activities. But this is different for everyone. And I think this is where being open with your provider about your goals is really important. Other reasons that we sometimes think about preventive treatment, even when headaches are occasional, is if it's really hard to find an effective acute treatment, which means that even though the headaches are only happening a couple of times a month, they're really interfering with function because they can go on for days at a time and the kid can't go to school. So there's lots of reasons. But in general, frequent headaches or significant interference with school or function is when I really think that better preventive treatment is needed.
You. And maybe Dr. Rao, can you talk us through some of the options that exist for prevention? Then that could be maybe we can do medications and supplements and leave some of the newest stuff and devices for a bit later.
Yeah, so there's a couple of different ways we can think about it. There are a few supplements that are out there. And again, the supplements kind of have to be discussed with your provider on what's going to work best for your child. So whether that's supplementing with magnesium or coenzyme Q10 or vitamin B2, there are a few out there. And then beyond that, there are medication options. There is two FDA approved ones, one of which we'll talk about a little bit later. One is approved for ages 12 and up, and that's an older medication that we've used for some time called topiramate. And beyond that, there may be others like amitriptyline, propranolol, valproic acid, or cyproheptadine. All of these medications really have to be tailored, right? We take this overall whole body approach. And so we talked a lot about medications, but I think beyond that, sometimes what's also really effective is when we look at cognitive behavioral therapy and biofeedback and thinking about how our migraine attacks as a whole, we know this is a lifelong disease. And so I kind of incorporate that with my patients because I want to give them the coping skills to be able to handle that. And so we know that cognitive behavioral therapy is really just this kind of highly effective evidence-based non-drug treatment for pediatric migraine. It can reduce our frequency and severity, and it teaches kids and adolescents how to manage their pain and their triggers and their stress by using different techniques, whether that's just with the therapy of cognitive behavioral therapy or in some places where you can use biofeedback, where they use skin temperature and such to help them. Now, this can be a challenge because if you don't have those in your area, it is a little difficult, but there are a lot of great apps out there that can be helpful too. So the kind of overall preventive approach really is so patient dependent through shared decision making to be able to determine what works best.
This is a really good point. Not everybody is going to make the same choice given the same options. So good to have a really collaborative relationship with whoever is helping you make those choices. And maybe we'll just talk a little bit again about the CGRP targeted options for prevention here. Dr. Irwin, can you tell us if things like GPANs or CGRP monoclonal antibodies are an option?
Yes, sure. So, I mean, the short answer is that they are a newer medication that has been more recently kind of studied and on market since around 2018 in the adult world, but are newer to the pediatric landscape. So I think the exciting thing is that we now do have one medication called fremanezumab or Ajovy, which is a little easier to say, that's approved from the age of 6 up if patients are of certain weight. That can be used in the pediatric population. The way to think about the CGRP medications is that we have some that are oral tablets that, can be taken acutely, like Dr. Green was mentioning. And then there's sort of two different categories of CGRP blocking medications in the preventive space. The one I just mentioned that is the new FDA approval, the Ajovy medication, is what's called a monoclonal antibody. So it's an injection that is given every 28 days subcutaneously, or there's different dosing regimens, but that's the most common, at home, by an injectable pen that looks sort of like an EpiPen, usually administered in the upper thigh. There are other monoclonal antibodies to CGRP that are approved in the adult space, but not the pediatric space, but are being, still studied in pediatrics. So you might hear about those when you hear about those medications. They're known as Aimovig or Emgality or Vyepti, and they all have other names as well, like Arenumab, Galcanezumab, or Eptinezumab. There's also CGRP blocking medications that are oral that can be used as a preventive. So the one we use most commonly is called atogepant or Qulipta. The other way we use the CGRP class in the preventive space is with rimegepant or Nurtec, using it every other day. And those are oral options, which might be considered in certain scenarios. These medications, as a category, I would say, are usually not thought of as first line. They are medications that really require a certain level of disability of the migraine disease for us to move to that category. They usually require at least 2, sometimes more trials of other medications, as well as lifestyle interventions that Dr. Orr was talking about, and sometimes even non-medication treatment strategies to be layered in before we move to this class. Reason being is that, they're newer, and we don't have long-term evidence, especially in pediatrics, for certain off-target effects that they may have. I think as a class, we're excited about it. It's the first quote, quote, like on target medication we have. We know that CGRP, the protein Dr. Green was mentioning, goes up when you have a migraine. And if you block that protein, migraine attacks can be aborted. So we certainly are excited about kind of this class of medications being on target. Sometimes they may work faster, sometimes they may work more completely, but we also just need to be a little bit cautious. There are certain medical contraindications to using them, and less is kind of is known longer term. There are also, medications that can't be used with pregnancy or breastfeeding, so you need to be aware of that when starting those medications in later adolescence and early adulthood.
Thank you. Yes, we want to help and have great options without hurting our patients, without good long-term data. So I think this is another one of those, let's do this webinar again in a year or two, and we'll have some more information about those at that time. Maybe Dr. Rao, you can tell us about some of our complementary and alternative options that sometimes get a weird kind of name, and people think of them as sort of stuff to do if other stuff doesn't work. But I think we might talk a little bit about them as really good options.
Yeah, so I think, we can go back to a little bit about what Dr. Orr mentioned in terms of the evidence with exercise. And so increasing our exercise, sometimes even involving PT, can be really helpful with our patients with migraine attacks. Again, depending on where you live, working on our neck muscles, movement, and really just decreasing disability. And so that physical exercise has really been shown to help reduce those number of migraine attacks we're having. Beyond that, sometimes we talk about acupuncture, right? And so there is some more emerging evidence. We obviously need a little more data. We're not quite there yet to kind of make that recommendation, but there are more and more studies that are showing that that may be a potential option for our patient population. So hopefully, again, in those 3 years, like you mentioned, we'll have a little more data to be able to say, hey, this might be a really great option. Here are some people you could go to for that.
Okay, and maybe Dr. Irwin, one more for you. I think you do some research here. Can you tell us a little bit about neuromodulation device kind of options for acute and prevention for kids and teens?
Yeah, for sure. This is a really exciting space. So it's like the category is called neuromodulation, and basically it's, some device that modulates your neurologic system in some way, and they all do it in kind of various ways. But in the migraine space, there are now 3 devices that have indication or FDA not approval, but what do we say? FDA clearance for use in the pediatric space. One is called Nerivio, and it works on a mechanism called conditioned pain modulation. Basically, what that means is that it stimulates your pain receptors in your arm, but in a non-painful way, in order to recruit your brain's sort of own natural endogenous pain fighting chemicals to shut down migraine. It's akin to I say this sometimes and people look at me like I have four eyes, so maybe not everybody does it, but when I'm at the dentist and it hurts in my mouth, I always like put my nail into my finger and try to cause pain on my hand. And that's sort of the technique of conditioned pain modulation. Different to what some might be familiar called the gate control theory of pain, where when you stub your toe or your shin, you kind of rub it and you're using the mechanoreceptors to dampen the input signals for pain. That's a device that can be used to treat attacks. So putting it on for 45 minutes when you have an attack, or it can be used in the preventive space every other day to reduce frequency overall. And it's paired nicely with the mindfulness app on their software system so that there's some relaxation component to the treatment session. The other two devices that are approved in the pediatric space or cleared in the pediatric space are the vagal nerve stimulator. It's a non-invasive stimulation. It's basically like an ultrasound probe. You put on a little jelly and you put it on your neck over the vagus nerve, and that's supposed to help modulate some of the electrochemical changes in migraine. And then finally, there's a device called TMS, or transcranial magnetic stimulation, that looks kind of like an iPad, but much thicker, and you hold it on the back of your head, and you press a button to administer some transcranial magnetic stimulation pulses, and those pulses can be delivered either acutely to abort an attack or preventatively to reduce attacks over time. They are a nice option because of their non-medication strategy. They have acute and preventive uses, so it's kind of a dual option. But one major important caveat is that they are not generally covered by insurance, and they typically represent an out-of-pocket cost. Some FSAs will let you contribute towards it. Some of the companies are working with insurance companies, but I would say when you're thinking about neuromodulation and want to talk with it with your provider, it's probably going to also be a discussion a little bit about that it's not covered by insurance, and that's a major barrier for these devices, and something that we all as practitioners are working on the advocacy space to try to overcome.
Thank you. These sound also very exciting, different and exciting. Maybe just for our last bit before Q&A, we're going to touch base with Dr. Orr. I wanted to touch on something that you talked about a little earlier in terms of how can we talk to children about migraine without increasing anxiety and without this being something that runs people's lives. So how can we both monitor and support youth who are living with migraine?
Yeah, I think it's important to educate youth about what's going on with them. Even younger children can understand some of the simple concepts. One of the things that we've learned in some of our patient engagement work is that, and this was brought up earlier, there can be a lot of fear, either from the child and or the parent, that we're missing another diagnosis. So that concept of diagnostic uncertainty in the broader chronic pain space has been shown to hold people back in terms of their pain outcomes. So being very clear about what's happening in the brain at the level that the child can understand, and reassurance that although this is one of the most disabling disorders known to man, and it's not to diminish it, that there isn't any brain damage happening, and that we're confident in the diagnosis. And then helping the child to develop pain coping strategies. Yes, there's the medical part. There's also the non-medical aspect of that. Like we've been discussing things like biofeedback, meditation, deep breathing, stress management. I think is something that parents can really support the child with. And also thinking carefully about the attention that's drawn to the pain in the family, and how the parent talks to the child about the pain. So we want to acknowledge and validate pain. It's real, it is there, it is not fun, but also not constantly draw attention to it if that's not needed, because the attention and the pain systems in the brain are heavily interlinked. And the attention system has like a dial on the pain system where the severity of the pain can feel higher if the attention is always on the pain. So distraction is a very powerful technique to help support the child. And it's complex and it's a fine balance because we need to treat the pain and validate it as well. We have some data. I work with a lot of pediatric pain psychologists, and we need to publish this, although we've presented it at a couple of talks to look at parental validation. So that's how the parent validates or invalidates the child's pain. So validation is acknowledging that it's there. You know, this must be hard. Yes, it must feel difficult to have this. As opposed to, it's fine, don't worry about it. It's not that bad. So if parents validate their children more, their pain outcomes are better. But also, we don't want to draw so much attention to it if the child's not bringing it up.
This is a tough balance to find, it sounds. And so I guess this is something that would also be really good to try to talk to your own headache specialist about more of these details. And I think we have some good resources on the AMF website about trying to find a provider who don't have one, as well as reading a lot more about many of the topics that we talked about. So we're going to shift into taking some of your questions. And I do just want to say again, the recording for this is going to be up on our website at some point in the near future. If you want to go over some of it again or share it with people who also might be interested. And please do keep putting your questions in the Q&A as we go through them. We've got a wide variety of topics that we'll try to do our best with. Maybe I'll just talk a little bit. No, I will not talk. I will ask one of these questions. So there is a question about what to do when kids are having breakthrough attacks on prevention, and how can you balance acute treatment and medication overuse if people are having frequent acute attacks? And I don't think we've actually talked about medication overuse. So if there's somebody who might just briefly tell us what that is, that would be really helpful. I will pick one of you if there's not one who's really keen.
So we can think about
Dr.
medication. Yeah. So we can think about medication overuse in a couple of different ways. Sometimes we get tricked into thinking, well, only the medicines that are prescribed can cause this to happen. But we also know overusing medicines like acetaminophen or ibuprofen or naproxen can lead our body to get used to medications and potentially worsen our headache frequency. So what we'll usually say is limit those medications to no more than 2 to 3 times a week to kind of avoid that overuse process of this. And sometimes that can be hard and challenging, right? If you're having daily attacks, sometimes we'll say, okay, well, kind of think about the severity of that attack. What are you going to use during that time? And this is a great time to bring in a non-medication options like our cognitive behavioral therapy, the biofeedback, and our neuromodulation to be able to provide other options on those other days. We know that these attacks are going to ebb and flow. So there may be periods where they are more frequent, periods where they're less frequent. And so that's also important to understand in your goals of prevention. Where are you trying to get in that number and how can we get you there? So that's kind of how I practice in terms of overuse and prevention.
That's a really good point, remembering that maybe a week was just bad and you needed your medications more. And that doesn't mean that it will necessarily stay terrible. I also like that you're positioning some of those non-medication options really front and center as really good treatment options. Just because they're not medications doesn't mean that they're necessarily any better or worse. Dr. Green?
Yeah, I was just going to add, I think we sometimes um, maybe overemphasize the risk of medication overuse. We recognize that sometimes, as you said, like headaches are really frequent, like you're having it's finals and you're having a really tough time, or you were sick and you need to take medication more often. I think it's important to remember that medication overuse is really a pattern of very frequent use over time. So one bad week doesn't mean that your headaches are going to get much worse from taking Advil a couple of extra times or ibuprofen a couple of extra times. And then I would say I also do use that as a guide. If it does become a pattern of more frequent use, that's an indication to me that preventive therapies aren't working as well as they should be. And that's where we can be making adjustments to hopefully better control headache frequency so that we don't need the medications as needed as often.
Maybe one more sort of related medication overuse question, and I don't know the answer to this. I hope one of you does. So there's a question about what happens if you put children on something like a triptan. Are they more likely to have issues as they grow older, for example, needing those things more often or getting medication overuse?
I don't know that we have great data on this, honestly. Maybe somebody else does, but I do know that in adult studies, it's actually been shown that more effective as needed treatment can decrease your risk of progressing to a more chronic or frequent migraine pattern. And so I would actually worry about the opposite, that undertreating migraine can actually result in a pattern of sort of pain building on itself and getting more frequent over time. So I really do encourage people to effectively treat their migraine when it happens, so that their brain doesn't start to cycle into more bothersome pain patterns.
Or look like you had something to add to that question.
No, pretty similar. I just want to say I don't think
Okay.
there's data, and it's that balance, like with triptans and over the counters of the, avoiding medication overuse, but within the limits of use, really leveraging the acute treatment to reduce the exposure of the brain to pain that's long and over again. I like to say our pain pathways may start out as a dirt road, and then if there's long and lots of pain, they get paved, and then it's a highway and a superhighway. So we do want to use the tools that we have to shorten exposure to pain, to prevent actually the brain from itself becoming better at giving pain over time. So I'm more worried about that than I am about kind of medication use in the appropriate amounts.
Right. Maybe one more acute treatment question. So there's a question about someone who was recommended caffeine as an acute treatment. Is that something that you have seen or have any views on?
I can take a stab at that one. Caffeine is frequently sort of cited as something that helps abort attacks. And I think it's most likely because caffeine acts as a vasoconstrictor on a receptor called adenosine. And so that can kind of shut down some of the vascular component to migraine generation, similar to how, triptans work in a way with the vasoconstrictive properties. I think most of us worry about caffeine being used as a treatment because caffeine withdrawal can also be a frequent trigger for migraine. Caffeine taken later in the day can inhibit or impact sleep, which will also, lower your threshold to have a migraine attack. And in a lot of our patients who are young, caffeine exposure in kind of the developing brain, I don't think we have enough data on for early and consistent use of caffeine in that population. So I generally stay away from kind of using caffeine. Also, the kind of modality that teens are typically getting caffeine also comes with a lot of sugar and other things in it if they're doing it in like a Monster energy drink or a drink from Starbucks, and that will also kind of change our energy shifts and can be problematic for migraine long term. So I generally stay away from it, and am not a huge fan of kind of combination treatments like Excedrin, for example.
Thank you. So maybe we'll talk about some prevention questions. There's a question about how feasible it is to actually get approval for fremonezumab or Ajovy in pediatrics. And maybe I'll direct that to Dr. Green. Do you have experience with this?
Yes, I have a lot of experience with this. I think that I have had a lot of success actually getting insurance approval for these medications, but typically in patients who have tried several other more sort of like well-established migraine preventive treatments, it's actually ends up being fairly similar to what we see in adults. If parents have migraine, they're often very familiar with this process where you have to have tried two medications from three different categories for a sufficient trial to sort of exhaust those options first. But once that happens, I do often have success getting insurance to approve fremonezumab, especially now that it's FDA approved in the pediatric population. It does sometimes, actually, I would say always require a prior authorization process, and then often also requires a letter of appeal from our office, but that's usually successful.
Is that experience that people in other bits of the states are having as well, Dr. Rao?
I would agree. I think that, it's nice to have options when you have contraindications to either acute or preventive therapy that we can't use. And so now these are options. And I find in my experience, that is when it is a little bit easier to get approved. Or like Dr. Green mentioned, we've tried those therapies before and we're able to do it. Sometimes I've even had parents advocate too by writing to the insurance company, documenting disability, ER visits, urgent care visits can all help in that approval process, but it's definitely a possibility. And again, 3 years down the road, I think this is going to be a totally different conversation that we're going to be having. But just having one at least in our arsenal that's approved is really helpful at this point.
And I'll just add, I mean,
Sorry, go ahead.
it's not always feasible for every family and every situation, but if you and your provider do think a CGRP mechanism medication, be it the injectable or the oral tablets, are something that you're looking for and you're running into roadblocks with insurance, one possibility to explore is to look for sites that are doing clinical trials, because a lot of trials are ongoing in this medication class for pediatrics. And so, if you are a good candidate and you don't mind some of the things that go along with clinical trials, like more frequent visits and maybe lab draws, it can be an avenue to potentially get the medication bypassing insurance if you're kind of the right candidate.
It's a great point. This is how we get new medications approved, is through people joining trials. And there's a related kind of question about why CGRP targeted therapies are not currently first line in kids. We've said some things about tolerability. So why are they not first line?
Well,
Maybe Dr. Orr, can you?
Oh, go ahead,
Go
Dr.
ahead,
Orr,
Dr. Kate.
please. I was just going to say, even in the adult population, the American Headache Society, I think, has argued that they should be considered first line treatments, but they are more expensive and they're relatively new. And for those reasons, I think from a resource standpoint, it often still makes sense to try other less expensive preventive therapies if those are options for your patients. If there's reasons they can't be taken, that's a whole other story. And then I echo what Dr. Irwin said in the pediatric population. This is just a relatively new class of medications, and we don't have long-term safety data in either adults or children and adolescents. And we don't really know how these medications affect developing brains and developing bones and other parts of the body that CGRP might act. We really think, and we have lots of good reason to think, that these are very safe and well-tolerated medications, but we just don't have the long-term experience with them that we do with some of our other standard therapies. So I think balancing sort of like risks and side effects and all of that, we often err on the side of using more established treatments first if we can.
And just to add to that, so we know there was a trial that was done a few years ago out of Cincinnati Children's that basically showed that pill-based preventives, 2/3 of kids will have like what we define as a treatment response, which is a 50% or greater reduction in headache frequency with daily pill-based preventives. And it may not matter so much which one we choose amongst the ones that have some evidence for migraine in kids. So if we can get the majority of kids to respond to pill-based preventives that are less expensive, and there are options that are very low side effect, then we think generally that still makes sense, especially in the context of, like Dr. Green was saying, the lack of long-term safety data.
Maybe one more question. Any thoughts about how to treat fatigue that can be associated with chronic migraine in kids?
Take a stab at that. Fatigue is really common with chronic migraine, and I think one way to think about, well, something that needs to be unpacked with you and your provider is, is the fatigue kind of secondary to the migraine itself, like the disease itself causing some fatigue when you're having an attack, or might the fatigue be a little bit more multifactorial? And so, oftentimes, especially in patients who are having frequent headaches, other things that we recommend in the lifestyle will be harder to be consistent with. So it'd be harder to have regular sleep, have good nutrition, have regular exercise, and all of those things will help combat fatigue and contribute to energy. So usually when I am sort of dealing with fatigue as being very problematic in someone with chronic migraine, often it requires kind of a little bit more of a deeper dive into what does the rest of the lifestyle look like, and is it just the impact of the disease, which maybe we can improve with treatment, or are there other things that could be modified in the lifestyle that might improve the level of fatigue? Generally speaking, and I think most of us would agree, we usually don't prescribe medications to kind of counter fatigue, both because there's not great evidence for it, but also because most of the side effects of medications that combat fatigue are headaches. And so it can become a little problematic to do so. I'm not sure if others have a different approach to that one.
Maybe since we are just about at time, I'm actually going to say thank you for that great answer. And I'm going to ask each of you, please, for one sentence that's your sort of take home about treating migraine in kids and teens. Dr. Green?
Oh, you put me on the spot there, the first
I
one.
did.
Gosh. Um, I would say that I would encourage families to remember that we, as headache specialists, really recognize migraine as a complex neurobiologic condition that really causes real symptoms of head pain and other symptoms like nausea and fatigue and trouble concentrating. And we really do recognize the impact of those on your life and your child's life. And to also remember that there are really so many different options for taking care of kids and teens with migraine. And it's not a one size fits all approach. I think it's important to educate yourself about the options that are out there, which you're doing by being here today, and talk to your doctor about what might be a good fit for you, even beyond what we think of as sort of standard treatments.
Amazing answer. I think you said most of the things, but Dr. Rao, do you have a one sentence takeaway for us?
I mean, mine is always that positivity at the end. I know you're going to get better at over time. We're going to help you get there. It may take me a little bit of time to get to the point where we figure out what tools you need in your toolbox to achieve decreased headache frequency, but we can get there. And I think that's really helpful because I think that a lot of times by the time patients sometimes get to us, there's this feeling of loss of hope. And I always think that migraine is a treatable disease. It's not curable, but it's treatable, and we have really great options out there.
Dr. Irwin?
I have a screaming 3-year-old in the background, and I'll keep it brief. I think I would say we can help. There's lots we can do, and we're here to help. We love helping. So work with us, and we will help you find the road to whatever success looks like for you at that time.
Or last word?
Yeah, I think most of what I wanted to say has been said around hope, but I think the maybe just adding in the concept of empowering your child and the youth, thinking about them transitioning to adulthood, empowering them with tools that are both medical and non-medical, and kind of making sure we work together to make the youth feel like they can take control over their disease management, I think is something to really focus on.
Beautiful way to end. Thank you all for coming up with those without being told in advance that I was going to ask you that. So thank you. Thank you all for your insights, and thank you to everybody who joined us tonight. It was a pleasure to share the evening with you. And please join us for our next webinar next month.